Good afternoon, everyone. Welcome to Better Medicare Alliance's Medicare 101 briefing. And I'm Mary Beth Donahue, President and CEO of the Better Medicare Alliance. And we're so pleased to have you all from the policy community, from the Hill, joining us today to discuss and hear from experts on Medicare Advantage. And hopefully you'll walk away learning more than what you came, and also we'll be hearing from you to learn more about what's top of mind. I'm just going to speak for a few minutes because I look at this as you coming today to hear from Matt Kazan from Avalere and our panelists, who I'll be introducing shortly. I did want to just do a bit of an introduction on BMA and a bit of context to why we are here today. The Better Medicare Alliance is a not-for-profit alliance that exists to strengthen and protect the Medicare Advantage program. And we do that on behalf of and working with our over 170 allies and our over 160,000 beneficiaries. And when I speak about our allies, again, those are the individuals who will be on our panel today. They're organizations that are in communities, aging service organizations, community-based organizations, also health plans, providers, business groups. So really, anyone who's in the MA space in the community represent the diversity of our membership in the Alliance. A few points that I did want to highlight just as I give context to why we're here today is when I say that we represent the allies and the beneficiaries, we're here strengthening a program that serves over 28 million seniors and individuals with disabilities. That's nearly half of all Medicare eligible adults who are now enrolled in Medicare Advantage. And CMS projections show right now that Medicare Advantage will enroll over half of the Medicare beneficiaries by 2023. And it's really important to appreciate the number of MA seniors that are in the population. And it's also important to understand who those beneficiaries are. They are individuals who live at low and middle income. More than half live below 200% of the poverty line. And enrollment in MA among beneficiaries also include dually eligibles, and that's increased in Medicare, Medicaid by 125% since 2013. So it's important to capture the population that's served in MA who are low income, minority, and duals. And important that in our discussion today to appreciate how the program brings benefits to those individuals. Also, as I mentioned, the minority community and the diversity, we represent 53% of Latino Medicare beneficiaries who choose enrollment in MA and 49% of Black Medicare beneficiaries. And the last fact that I'll throw at you before I introduce Matt Kazan from Avalere, who will go through a bit of an introduction to Medicare Advantage and also speaking to the proposed rule that came out recently, is that Medicare beneficiaries have the higher rate of social risk factors, and that includes food insecurity, and that's compared to original Medicare. And there's a greater proportion of Medicare Advantage beneficiaries who have 3 or more chronic conditions. And again, as you hear from our panelists, you'll hear more about those conditions that are treated by primary care doctors in the relationship with patients as part of the coordinated care in the Medicare Advantage infrastructure. You'll hear also on the supplemental benefits that I just referenced, and also the value-based care and the importance that that brings to seniors and why they choose Medicare Advantage. So I'm going to go on and introduce Matt, who we're so happy to have with us. And as I mentioned, we just got through in the middle of reviewing a proposed rule that we'll comment on. And we have an upcoming rate notice that we're all anticipating to hear what changes may be made to the Medicare Advantage program. And Matt will be able to speak to the proposed rule, but really start with a kickoff of what Medicare Advantage and the program is, because we realize we have a diverse audience who have called into this webinar, and we want to ensure that we both capture the overview of MA, but also get to some of the technical issues as well. And so there's no better person than Matt to do that. Before I introduce Matt, I do want to just refer to our panelists who I'll introduce later. We have Dr. Jerry Penso, who's president and CEO of AMGA, Ipyana Spencer, who is the chief health officer with Meals on Wheels, and then no relation, Dr. Kevin Spencer, who's chairman of the Premier Family Physicians in Austin, Texas, and he's a chief clinical partner with Agilon Health. So again, I'll introduce our three BMA allies on the panel later, but I do want to turn to Matt now. And many of you know Matt, who plays a critical role at Avalere and the health plan and science client space of Avalere, providing strategic advice to organizations like BMA who have benefited from his expertise and the experience of his team. Also, Matt served on Capitol Hill, where he spent over a decade working on the Senate Finance Committee under Senators Max Baucus and Ron Wyden. And in those roles, Matt was the primary policy advisor on issues including Medicare Advantage, Medicare Part D, and also the Medicare and Medicaid program. So there's no better person for us to be able to have to kick off this webinar. So Matt, I'm going to turn to you.
Well, thank you, Mary Beth, for that very generous introduction, and thank you for the invite to speak to folks today, especially some of my former colleagues on the Hill who I know are doing great work. And so, as Mary Beth said, my purpose today really to give folks kind of an overview at a very high level of the Medicare Advantage program, how it's different or similar than the fee-for-service Medicare program, and then dive into some of the more impactful or notable proposals in the recently released proposed rule that CMS put out earlier this month. So thinking about kind of Medicare Advantage versus fee-for-service Medicare, if we advance to the next slide, we'll go one more. Perfect. Medicare beneficiaries obviously have a choice when they on how they want to receive their Medicare benefits. They can choose between Medicare fee-for-service, which is a structure where a beneficiary can go to any Medicare participating provider, and that provider is paid directly for the services by the federal government. Medicare Advantage, slightly different in that the beneficiary enrolls in a Medicare Advantage health plan, and that health plan is responsible for providing all of the Medicare covered benefits and services that are dictated by law and regulation. And the federal government, rather than paying those individual providers, pay a kind of per member per month payment to the health plan, adjusted for a bunch of different factors that we could get into. But that's really the major difference in the structure of the two programs. And as Mary Beth said, the trend over time has been that more and more beneficiaries are choosing Medicare Advantage, and the proportion of beneficiaries in the Medicare Advantage part of the program is expected to be more than half in the near future. So if we drill down a little bit on the next slide on some of the real key differences that impact beneficiaries when they're thinking about which direction to choose. On the benefit side, Medicare Advantage is required by law to cover every single benefit that is provided under Part A or Part B. And in addition, almost all, I think, in the 90–95% range of plans also offer the prescription drug benefit. So it really is a structure where all the benefits that are provided under Medicare is provided by a single health plan. In addition to those benefits that are provided, required under law, Medicare Advantage plans often offer what's known as supplemental benefits. These are benefits that are not offered under traditional Medicare. Those benefits really take kind of two forms. Number one, either lower cost sharing or lower premiums than what is generally paid for in fee-for-service, or kind of healthcare or social related benefits that are not offered by traditional Medicare. So you often hear things, and I'm sure we'll hear a lot from the panelists later in this agenda, things like nutrition, transportation, housing support, things that aren't offered under traditional Medicare. We're seeing a lot of health plans really take up those types of benefits and offer it to their enrollees. That's on the benefits side. Thinking about how beneficiaries access services, this is a major difference between fee-for-service and Medicare. Medicare Advantage plans are required to meet network adequacy requirements so that their networks have a sufficient number of providers available to their enrollees. And they're not required, as in fee-for-service, to have a much kind of broader array of providers that you could go to, a beneficiary could go to. Beneficiaries do have the flexibility in most cases to see out-of-network providers, but oftentimes there's kind of reimbursement or cost-sharing consequences to that. Speaking of cost-sharing, I think there's a couple of general rules to think about. For the most part, Medicare Advantage plans have some flexibility to set cost-sharing higher or lower than fee-for-service, with the exception of some services where Congress has said Medicare Advantage plans, your cost-sharing cannot be any higher than fee-for-service cost sharing. So instances like Part B drugs, chemotherapy drugs, some of the COVID-related services were added to that list in recent times. CMS looks at cost sharing and other benefit structures to determine that MA plans don't discriminate against beneficiaries based on health status or other factors. And then one particular kind of difference between MA and fee-for-service that I want to call out because it's pertinent for the proposed rule that came out is that unlike fee-for-service, Medicare Advantage plans are required to have an out-of-pocket limit for the beneficiaries, meaning that once a beneficiary's out-of-pocket costs hit a certain threshold, the plan bears all of the remaining cost sharing for the rest of the year. Now, CMS sets kind of a maximum dollar amount limit of what that should be every year, but plans have the flexibility to go lower if they so choose. And so that is a key difference between the MA and fee-for-service parts of the program. So if we advance one more slide, there's also a difference on quality, right? We see Medicare in many different instances measure quality, adjust payment to stakeholders based on the quality, and Medicare Advantage is no different. CMS established a quality system. It's often referred to as the 5-star rating system, where plans are rated on a scale of 1 to 5 stars based on a host of different factors that look at plan performance, everything from beneficiary outcomes on certain things to process measures that the plan ought to be doing, as well as the beneficiary's kind of interaction with the plan, how kind of consumer friendly, so to speak, is the beneficiary or is the plan for the beneficiaries. This slide illustrates some of those categories that plans are rated on. And they're rated on each year. And CMS and Congress, through the Affordable Care Act, called for plan payments to be adjusted based on star rating so that if plans reach a certain benchmark, their payments will be higher. If they fail to reach a certain quality minimum, their payments are lower. And so somewhat similar to some of the other kind of quality pay for performance programs in Medicare, it certainly is a big aspect of the Medicare Advantage program. So if we advance one more slide on our 101 section, Mary Beth touched on this. I think these projections are probably a little conservative and ought to be updated with recent kind of enrollment data. But as you can see, Medicare Advantage, when the Affordable Care Act was passed, represented 25–26% of the total program. That's grown, as you can see, since the passage of the Affordable Care Act, and CMS, CBO, other independent experts project that growth is going to continue to increase, if not accelerate, and that at some point in time, we'll be looking at a scenario where there will be more beneficiaries of Medicare Advantage than there are in fee-for-service Medicare. So that's my 6-minute Medicare Advantage 101. You are all experts on Medicare Advantage now. We can talk a little bit about kind of recent developments in this space. Every year, much like fee-for-service, there is a regulation that CMS puts out around Medicare Advantage and Part D. That recent regulation came out. It is for plan year 2023. As you can see from this slide, there's a bunch of different policies that CMS has thrown out to stakeholders to comment on. Those comments are due March 7th, so you still have got 5 or 6 weeks to get those comments in, or letters to the administration. I'm not going to focus on all these proposals because it is quite of a big rule, but I want to focus on some of the more impactful or major provisions that you're likely to hear about from stakeholders, from the press, from CMS, et cetera. So we'll dive into 3 of those here, starting with, I think, the out-of-pocket limit proposal on the next slide. So as I said earlier, right, Medicare Advantage plans require to have a maximum out-of-pocket limit. To progress towards that limit, a plan simply adds up the amount of out-of-pocket spending that an enrollee incurs over the year. And let's say that out-of-pocket limit is $5,000, making up a number for a particular plan. Once that beneficiary has reached $5,000 of out-of-pocket spending, all future cost sharing for the rest of the year is borne by the plan. Now, CMS has proposed kind of a change to how this calculation is met, specifically for enrollees that are dually eligible for both Medicare and Medicaid. Some dual eligibles have their cost sharing paid for by state Medicaid programs, and they themselves do not pay any out-of-pocket obligations out of their own pockets, essentially. What CMS has proposed here is to count the portion of out-of-pocket costs that are paid for by the state Medicaid plans toward that enrollee's progression to this out-of-pocket limit, essentially increasing the speed by which these dual eligible beneficiaries will reach that out-of-pocket limit, and none of the costs will be borne by the state Medicaid program or the beneficiary. CMS projects that this proposal will save the Medicaid program a couple $2 billion, but they also project that because health plans will bear more of the costs, health plan costs and Medicare costs will increase. And so this is an important provision to think about the impact on beneficiaries, out-of-pocket spending, on state Medicaid program spending, but also Medicare Advantage obligations. This will affect all Medicare Advantage plans, but will impact Medicare Advantage plans that enroll more dually eligibles than other, given that that most of this proposal really is focused on that particular patient population. So when you're thinking about the Medicare Advantage proposals in this rule that from a dollar and cents standpoint are the biggest impact, this is probably number 1 on that list. So if we go to the next slide, on the Part D side, there is a kind of similar proposal in that it will affect kind of government spending. And so this obviously is a proposal related to Part D, but as I said earlier, most Medicare Advantage plans offer the Part D benefit. So Medicare Advantage plans are also implicated in this proposal. And so you'll often hear this proposal referred to as the pharmacy price concessions proposal, or DAR, a bunch of kind of complicated terms that have to do with health plan reimbursement to pharmacies. And so essentially, what has happened over the years is that health plans will reimburse pharmacies to dispense drugs to Medicare beneficiaries. And through a variety of programs related to quality or other provisions, that reimbursement from the health plan to the pharmacy is adjusted up or down, depending on a bunch of factors. When that reimbursement is adjusted downward, that's known as kind of pharmacy DIR, and it gets into a complicated formula that allows for lower plan bids, lower plan premiums, a complicated kind of formula that we don't need to get into. But I think CMS's proposal here is really speaking to the concern from the pharmacy community that their reimbursement has a lot of volatility to it, a lot of unknowns to it. And so what CMS is proposing is to require that pharmacy reimbursement be based on basically the lowest possible price that a health plan could reimburse to a pharmacy, and then allow for those upward adjustments at a later point, if applicable. Why this matters to a beneficiary and to health plans is that cost sharing for that drug that's dispensed at the pharmacy is based on that health plan reimbursement. So if CMS is making health plans reimburse those pharmacies at a lower level than today, cost sharing for beneficiaries at the pharmacy counter will be lower. Why it matters to health plans is that kind of recoupment of payment from the pharmacy to the health plans is invested back into lower bids and lower premiums. And so there is this push and pull debate between premiums and out-of-pocket spending, and where is the correct balance. And so that's something to think about as part of this proposal as it relates to the pharmacy price concessions. So the third proposal that I wanted to highlight, I'm cheating a little bit because I've lumped in a bunch of proposals kind of into one theme. And this relates to, again, back on the dual eligible population. There's a specific type of Medicare Advantage plan called a special needs plan. These plans were created by Congress and CMS to really target specific types of beneficiaries and design kind of a care model around their specific needs. And so one type of this special needs plans focuses on the dually eligibles. On top of that, CMMI and the Duals Office, again, created by Congress through the Affordable Care Act, has been running this demo for a couple years now, creating these Medicare Medicaid plans or duals plans that are really testing a new way to deliver care to dually eligible beneficiaries. And they've done this through a host of different kind of approaches and rules than the normal Medicare Advantage program. What CMS is doing in this proposed rule is saying, let's take a bunch of learnings and rules from that CMMI demo and apply it to the broader Medicare Advantage and specifically DSNP program. So things like allowing beneficiaries to have a role in advisory committees within a plan, simplifying the appeals process, requiring that marketing materials be more integrated. These are all things that the MMP program or the Duals Plan program have been doing for a couple years now, and CMS is proposing to apply them to a broader set of beneficiaries. So for stakeholders, for staff interested in the duals space and the duals demo in particular, this is something that you want to really keep a close eye on, evaluate what's appropriate, what's not appropriate in terms of applying some of these specific changes to the broader program. So those are the three big proposals that I wanted to call out. As I said, again, there's a bunch of proposals. Comments are due March 7th. And if that wasn't enough kind of Medicare Advantage fun for you, we expect CMS to release the annual kind of advance notice this week, early in February. This is the kind of regulatory document that deals with payment to Medicare Advantage and Part D plans. We expect both the rule and this rate notice to be finalized in early April. And so there will be a lot to talk about on the Medicare Advantage front, first with this rule and then this rate notice that we expect very shortly. So with that, Mary Beth, I will kick it over to you and see if there's any questions. And then I know we have a great panel of experts right after me, so do not want to hold that up as well.
Thanks, Matt, and thanks for that presentation. Questions from our webinar attendees?
It looks like we've got a couple questions here
Sure.
in the queue. And I'm just reading this for the first time, so bear with me here. But there's a question that says, are there any MA plans who offer a core or supplemental benefit of additional lifetime days of inpatient psychiatric care and freestanding facilities beyond the fee-for-service Medicare 190-day lifetime limit? Or must it be purchased via Medigap? Is there any regulation that prevents MA plans from offering additional days as a core or supplemental benefit?
No, it's a good question. There definitely are no kind of prohibitions on Medicare Advantage plans offering a more robust set of benefits that are offered under fee-for-service, like the specific example in the question. I couldn't tell you offhand, but we could go back and look at the data, how many plans are offering this particular type of benefit. One other response to that particular question, they asked about Medigap. CMS rules do not allow beneficiaries to enroll in both a Medicare Advantage plan and a Medigap plan at the same time. Medigap plans are really limited just to beneficiaries who are enrolled in fee-for-service Medicare.
And then there's another question here that says, does CMS's proposal have any language that treats Medicaid fee-for-service and managed care plans differently when it comes to counting toward out-of-pocket limits for dual eligibles?
No, that's a good question. My understanding of the rule is that any payments made by the state Medicaid program on behalf of the beneficiary would count towards that progression towards the out-of-pocket limit. So whether that dually eligible beneficiary is getting Medicaid fee-for-service or Medicaid managed care, the rule should treat them the same as far as that cost-sharing assistance.
Jonathan, no other questions?
It looks like there are no other questions in the, I'm sorry, we just had one that just came through. Are you able to speak to the MA Give Back program? Is this information located or identified in the Medicare Plan Finder? And does the program provide 100% reimbursement to all beneficiaries enrolled?
I'm not 100% familiar with what the question's referring to in terms of the Give Back program. I'm happy to follow up with them specifically. It could be just an issue of terminology that I'm not familiar with.
Great, thanks for the offer, Matt.
Absolutely.
Any other questions, Jonathan?
No other questions in the queue.
Okay, I did want to squeeze in one question before I turn to introducing the panel, Matt, is again, just given your expertise and insight, I always want to be able to get your perspective on the environment, and the current environment we've both mentioned is the upcoming rate notice. What policy issues could you sort of speculate on seeing in the upcoming rate notice that we should watch for?
Yeah, I mean, so it's important to think about the rate notice in terms of payment, right? The central purpose of that rate notice is to have CMS propose things that affect payment to health plans. CMS often responds to kind of external stakeholders that are talking about issues in the Medicare Advantage program. And one issue that's gained a lot of attention from GAO, IG, other kind of external stakeholders is this issue around coding intensity and coding practices of plans. And, we don't have time to go into the kind of pros and cons of the particular issue, but I think given the level of chatter of the issue generally, I would be very surprised if CMS does not propose something related to coding or coding intensity or some sort of response to something, all the incoming that CMS is getting on that issue.
Thanks, Matt. All right, well, we're going to give Matt a break here, and we're going to now turn to our panel, where I am so happy to have our three BMA allies with us today. And I'm going to first introduce Dr. Jerry Penso, the president and CEO of AMGA, the American Medical Group Association. Dr. Penso is a board-certified family physician with a Doctor of Medicine from the University of Southern California in LA and his MBA from San Diego State University. And as president and CEO of AMGA, which is a trade association, he represents medical groups and specialty practices across the country, where they collectively represent over 175,000 physicians who care for patients. Also joining us, Ipyana Spencer, Chief Health Officer at Meals on Wheels America, which, as many of you know, is the organization that supports over 5,000 community-based programs across the country dedicated to addressing senior isolation and hunger issues. Ipyana brings us more than 2 decades of experience in advocacy, healthcare policy, and public service. Ipyana also worked on Capitol Hill for Senate Majority Leader Chuck Schumer, and she was also VP of Community and Strategic Engagement for United Healthcare Community Plan. And finally, as I mentioned, we have Dr. Kevin Spencer with us, a primary care physician and chairman of Premier Family Physicians in Austin, Texas. Dr. Spencer is also chief clinical partner for Agilon Health, and that's where he works with primary care physicians around the country as they're implementing global risk in Medicare Advantage. So welcome all of you, and I look forward to engaging each of you in questions and having the audience hear from you on where you serve and work with our beneficiaries and other allies in the Medicare Advantage program. I am going to kick off with posing questions to Dr. Penso, as he was one of the founding allies of BMA back in 2014. Dr. Penso, I think it would just be really helpful, again, as a founding member of BMA, for the attendees to just hear your association's interest in MA, and over this time, how you've seen the MA landscape change.
Well, Mary Beth, I'm delighted to be here and representing, as you mentioned, 450 medical groups and integrated health systems. We're in all 50 states. We represent over 170,000 physicians, but more importantly, the care teams that work with these physicians that treat over 1 in 3 Americans. And over time, what there has been is a great match between the care model that these groups have, as well as the benefits of Medicare Advantage. The care model that these groups have is multi-specialty with a strong primary care base. They have a common electronic health record, so all the doctors and care teams can talk to each other on one system. They have advanced population analytics, and I'd love to talk more about data and analytics and how important that is to giving great care today. And team-based care, that's where doctors, nurses, pharmacists, care coordinators all work together to give care to patients. And as Matt mentioned, those patients with chronic conditions or more than one chronic condition are ideally suited to this model. So because of that care model, which I believe is ideally designed for value, our medical groups and health systems have really moved strongly into Medicare Advantage. And it is now the dominant preferred value payment model for those medical groups and health systems. And there's 3 main reasons why, and why we're a strong founding ally of Better Medicare Alliance and continue to be a strong advocate for Medicare Advantage. Number 1 is the payment model. Matt mentioned that it's unique. It's a per member per month payment that comes into the health plan. That stable, predictable model really helps the groups plan and deliver the best care possible. The second is the consistency and the known rules. Medicare Advantage has been around for decades. The rules are known. It doesn't change like some of the other risk models that are out there. So we can really do the planning over the long term. And then that brings me to the third part, which is investments. That combination of a stable payment model, consistent known rules, really encourages investments that can help take care of the patients better while lowering costs. Again, it's that flexibility in the rules compared to traditional Medicare. And as Matt mentioned, there's an enrolled population, so we know exactly who to take care of, and our analytics tell us the best way to do so. So I'm thrilled to be here and a big supporter of Medicare Advantage. I guess the only other thing I want to mention as a family doctor, I cared for patients who took care in Medicare Advantage. It is great for patients as well, because patients have the advantage of knowing that their system, their healthcare system, is really aligned around giving them great care and keeping their costs low.
Thank you, Dr. Penso. When you speak about the model, it's a really timely opportunity to ask you this question, as we're still in the midst of COVID-19, and it's known that there were challenges that were posed to physician offices who lost fee-for-service revenue during those early months. And just as you talk about the care model in Medicare Advantage, it's known that that value-based contract with providers helps sustain, many of those practices during those difficult months. And again, given your unique perspective of having been a family physician, can you just speak to how your physicians and groups dealt with those early days of COVID-19 and the role that MA played?
Yeah, those were challenging days. If we rewind back to March, April, May, June of 2020, those were times when we had many lockdowns. And during those times, patients, as well as our medical groups and health systems, encourage people not to come to the offices, not to come to the hospital, unless they had serious or emergent type of conditions. So all sorts of practices were encouraging patients to stay home unless they really had to come in. Now, given the current dominant payment system that's out there, fee for service, when those volumes decreased, then the revenues decreased as well. And it was very challenging for groups around the country, provider groups, to deal with that. Mainly, it was a cash flow issue. They're usually dependent on the cash that comes in from those visits to sustain the operations. And medical groups and health systems across the country had staff layoffs, furloughs, compensation, and salary cuts during those times. Medicare Advantage, which is a payment model that provides a per member per month, was like a lifeline to many of these groups, because what it did is, if you will, sustain the cash flow for that patient population and really help those practices survive during those tough times. I want to make one point about those payments in case people think that was a windfall. Those payments were necessary to take care of the patients later in the year. When the patients start coming back, there was a backlog of things that needed to be done for those patients, maybe mammograms, colonoscopies, all sorts of services that still needed to be provided. So that money that was provided during those months when the patients didn't come in was used the rest of that year to take care of those patients when they did come in with all sorts of issues that had been delayed.
One more question, Dr. Penso, as we move to others on the panel. And you've been talking about value-based care, and I know this is Healthcare Value Week. Is again, on a reflective point, in your view, what do you think needs to be done to realize the full potential of value-based care, and not just in MA, but across healthcare?
Oh, thanks. Great question. We at AMGA are committed to value-based care, and we work closely with our medical groups and health systems to move them in that direction. And we ask them, every year we do a survey and we ask them, what are the barriers to moving to value-based care? Number one on their list is data exchange. To make this work, you need information, you need data on your patients. And no one has all the data on the patients, but the health plans as well as the medical groups combined have that combination of what we call electronic or clinical data from our electronic health records, as well as claims data, because a patient can go outside that medical group and get services. And it's important that the physician practices know all of that. There are barriers to that data exchange, and we support making sure that that data exchange occurs so that the health plan as well as the medical groups have all the data that they need to take care of the patients. I'd say number two is partnerships. There has to be a partnership between the health plan and the medical group to make this work. It's got to be a trusting relationship, because not just data exchange, but all the coordination that needs to happen to make sure that that patient gets the best care. And then finally, the answer is time. The transition from fee-for-service volume-based care to value is not an overnight journey. It really is a culture change, and our medical groups and their leadership need time to adjust all their systems, their care coordination systems, their financing systems, and their accounting systems, as well as all the education that needs to go on with their physicians and care teams.
Thank you so much, Dr. Penso. And again, I know we could talk more about this, and I want to remind the audience we'll come to questions after we go through the remainder of our panel. So thank you again. And switching gears here as I pose questions to Ipyana with Meals on Wheels. The other area we focus on in the value of Medicare Advantage, we talk a great deal about social determinants of health, and the innovations in Medicare Advantage are very much seen in this space. And so Ipyana, can you share the work that you're doing at Meals on Wheels with the social determinants of health, and how your partnership with MA plans helps serve the seniors in need that Meals on Wheels is serving?
Sure. Thank you for having me this afternoon. And as you mentioned, Meals on Wheels America is the national membership and leadership organization that supports the network of more than 5,000 independent local Meals on Wheels programs in rural, suburban, and urban communities across the country, addressing food insecurity and social isolation for older adults and individuals with disability. For over 40 years, the amazing staff and volunteers of Meals on Wheels programs have directly addressed social determinants of health by providing nutritious meals, social connection, and safety checks that enable older adults and individuals with disabilities to live with independence and dignity. I want to just provide some context to the issue of food insecurity and social isolation. Before the COVID-19 pandemic, nearly 9.7 million seniors were struggling with some level of food insecurity, meaning they could not rely on access to sufficient, affordable, and nutritious food at all times. Food insecurity rates were higher for Black and Hispanic older adults, with the rates of food insecurity among Black older adults being more than twice that of white older adults. Older adults experience social isolation at higher rates, with 1 in 3 reporting they felt lonely, and about 1 in 4 older adults reporting that they lived alone. And we know that the pandemic actually did not help that, so the numbers are a lot higher as we're kind of still in the midst of that. And research has shown that older adults struggling with food insecurity and social isolation are more likely to experience adverse health conditions, including those that lead to hospitalization or inpatient care needs. The trajectory of our current aging services and our healthcare systems making a move towards more whole person and person-centered models of care delivery really positions community-based organizations like Meals on Wheels as an effective partner to help support the physical and mental health needs of older adults and vulnerable and underserved populations. And many of our partnerships with Medicare Advantage plans are based on this shared understanding of the value that Meals on Wheels services have and provide to disrupt that hospital and inpatient care need.
Thank you, Ipyana. I still want to stay on this theme of what Meals on Wheels is providing to Medicare beneficiaries in the context of these benefits. Today, BMA is releasing a study with NORC at the University of Chicago that thankfully Meals on Wheels participated. And it talks about this partnership that Meals on Wheels has with Medicare Advantage. And one of the fascinating aspects that came out of this research was to really see the insight that Meals on Wheels was providing to plans on what they saw as other social risk factors that were noticed when they were in the course of a visit with a patient and doing follow-up with those plans. And the opportunity that MA provided that kind of infrastructure for community-based organizations and health plans to work together. Can you elaborate on that?
Sure. Meals on Wheels programs are known for delivering meals, but they don't. Most people don't know that while they're actually visiting with seniors, they're making sure that their home environment and that the physical appearance of the seniors and the vulnerable adults that they're serving are in a good place. I think most often when seniors interact with the healthcare system, it's an admission, they go home, you have no idea how they're managing their health or what their home environment looks like once they leave. Meals on Wheels allows us to transfer information as being the eyes and ears of a lot of the kind of shared seniors that we serve to our Medicare Advantage partners. And that is absolutely crucial. I was thinking about something that Dr. Penso was talking about with respect to the data exchange. We often talk about that in a clinical setting and don't realize that the majority of people, we do realize, but we don't talk about it, that the majority of people do not live in a hospital or a healthcare setting. And so that collection of information is limited if you're only looking at clinical data. So the partnership that's cultivated between healthcare payers as well as health system partners is absolutely critical when it comes to including community-based organizations like Meals on Wheels, because we're able to fill in a lot of the gaps from knowledge that a care manager would not know because they don't see the home. We don't do video teleconference that often, that technology is not there. And they also, because they are local community-based providers, they have a different understanding of the actual geographic, the weather, they know the communities that they're serving. They're part of the communities that they're serving. And so they're able to provide a different lens about kind of what those seniors are dealing with in their homes, whether or not they are close to grocery stores, whether or not they're close to family, whether or not they're close to social supports, whether or not they're close to family caregivers or community caregivers, because we know in a lot of communities, your family is not just those people that you're born into some sort of blood relation with. And so the partnership is absolutely critical with that collection of information, that transfer of data. And I think as Jerry pointed out, that partnership and coordination that has to take place with not just clinical partners, but also with community-based partners like Meals on Wheels.
And Ipyana, a last question before we move to Dr. Spencer. You talk about the gaps in knowledge and where Meals on Wheels fills that, and ultimately there ends up being a gap in benefits because there are benefits unavailable in original Medicare. There's vision, dental, and hearing, and what you're just speaking to in the meal delivery. And, often there's, rhetoric that these are just seen as nice extra benefits and not really needed. But as you've been speaking to them, they are a lifeline for some of these individuals and their families. And if you can just, speak to the importance of adequate funding for this program, to ensure that these supplemental benefits are able to continue, like meal delivery.
Absolutely. And often when we talk about supplemental benefits, it does make it seem as though it is the add-on. But the reality is that oral health affects nutrition. If you have problems chewing your food, your nutrition is likely going to suffer. We all know that there are correlations between diabetes and vision. There are a number of interactions that we understand between food and various chronic conditions. And unfortunately, too many seniors as well as plans are forced to pick one that they're going to offer. And that's clearly problematic, especially as we're having conversations where we discuss whole person care, but we offer coverage or for parts of you. That's not always ideal, clearly. One of the things that we would love to see are consistent benefit offerings that actually allow for robust services like meal delivery to continue for more than just a post-discharge period of 1 week or 2 weeks. Chronic conditions take time to develop. They're not going to be addressed with a 7 or 10 day meal delivery benefit. And so having some sort of longer term, consistent, robust offering would absolutely go a long way to creating truly valuable outcomes for the seniors that we serve.
Thanks so much, Ipyana. I'm going to jump now to Dr. Spencer. And again, I introduced to him earlier as a physician in Texas. And this is just a unique opportunity to hear from someone on the front lines who's in one of the highest MA penetration areas in the country, which is at 47%. And, Dr. Spencer, I think we would all benefit from hearing from you on just what you believe the MA benefit means to seniors that you're, providing care to, and just their satisfaction with the program.
Yeah, first, thanks for having me, Mary Beth, and welcome everyone. In Texas, we are 47% penetrated, so 47% of the seniors are choosing in Medicare Advantage plan. In Austin specifically, that penetration is only 38%. Yet it's growing at 15% per year. So clearly the patients are choosing Medicare Advantage for reasons. We've educated providers on those reasons. We've asked and listened to our patients. What we know is our Medicare Advantage patients today, as we poll them, have an NPS score of 80 or higher that they have. There 94% of them say that they are receiving very high quality care from their provider. And over 91% say that they can have access to their provider whenever they want. And while I live in Austin, Texas, being with Agilon Health, and we partner with physician groups around the country, we're in very high need areas. We're in places like Texarkana, Texas, Longview, Texas, Pinehurst, North Carolina. We're in Southeast Ohio and Zanesville. We're in deep urban areas of Buffalo, New York, and Pittsburgh, Pennsylvania. And this is what our patients are telling them. And I think Ipyana mentioned some of the benefits that they speak to us about: a gym membership, vision, hearing, dental that they're not able to get with Medicare, and a supplement that speaks to them, transportation, food after admission with certain benefits that are provided. These are things that are speaking to our Medicare population. And on the provider side, Jerry mentioned this, our ability to see better in real-time data, and Ipyana is right, the claims and the EMR data is not enough, but compared to what we had, when we get that, it's a big step forward. And Medicare Advantage plans are able to provide us real-time data. That increases our ability to care for the patient. It increases the provider satisfaction. It's very disturbing as a provider when you don't have all the information with a patient that's sitting in front of you that's just got out of the hospital, that you know is at high risk of having something happen, and you don't have the ability to understand what that might be. So those are the things that we're seeing in our communities around Medicare Advantage, both from a patient perspective, but also the provider perspective. You know, we're seeing our ability with the sustainable payment model that Jerry mentions, at being able to invest in primary care. We're undervalued and underfunded historically, and we see that as changing, and a big part of that is having a sustainable model so we can make real investments in the care of our patients' needs, that we can then continue to invest ahead of the outcome in a model like that.
And Dr. Spencer, I know you've been, referencing the role of primary care and the importance of it. And so just to drill down a little bit as it relates to, again, the time during COVID and ways that you saw MA strengthen the relationship between beneficiaries and their primary care providers, because there is a gap when it comes to original Medicare. And I just was on a Zoom the other day with several organizations with Secretary Becerra, and the topic that we were focused on was increasing the awareness of vaccines, and obviously more recently boosters. And there's so many people in communities where they lack a resource to even have access to that. But one of the benefits of MA and the coordinated network-based approach is the emphasis on primary care. So if you can just speak to the importance of primary care as it relates to, COVID, and how you think it's helped in that beneficiary-physician relationship.
Sure, and I think at its base, pre-COVID, primary care has been a very important part of the healthcare delivery system. We know there is a shortage there, so we're beginning to look at how we would address that going forward. That relationship's so important. Number one is it's the place most of your screening and preventative care occur. So as you think about our senior population and the things that are preventable, vaccines being one great example, this is usually the venue where patients receive that. Second is, in a good healthcare delivery system, we can serve as the quarterback to help guide patients through the very, at times, fragmented and confusing system. So for that reason, oftentimes, because of the longitudinal nature of a primary care relationship, we also carry the highest trust and the longest relationship with our patients. That begins to be very important as they make healthcare delivery decisions that are more common later in life. The kind of decisions they're making are very different than, do I want to have this surgeon versus this surgeon do my knee operation? It begins to be really value-based, kind of faith-based decisions around what they would want with their life, and their primary care physician is often the place to do that. As it relates to COVID, as Jerry pointed out, our offices got empty in a really, really big hurry in March through June. We used that time to pivot and use technology, and more seniors than we realize can use technology. Certainly all cannot, and we need to think about that. We had patients drive up in our parking lots, and we would hand them a sterilized iPad so that they could interact with their primary care in a way they were comfortable with for the people who are technology challenged. But we literally, in most of our practices, were able to have a touch point with every single senior in our practice during that time. So we actually think that the COVID time is going to make primary care more important, because we reached out during that time to show them, you don't need to make your healthcare delivery decisions alone. We're here for you. And that goes for vaccines as well. We've reached out to all of our seniors to educate them on vaccines. I will point out that the national data on Medicare Advantage patients receiving COVID vaccination status is higher than the remaining other populations as well. And so those are just some of the ways that I think primary care is A, important, and B, what we were doing during COVID and really continue to do as the pandemic kind of continues.
Thank you, Dr. Spencer. I do have a couple follow-ups for the panel, but Jonathan, I wanted to check in to see if there's any questions from the audience.
Hi, Mary Beth. There's a couple just logistical questions asking if this will be available to watch at a later date. And I know we do plan to put this on our YouTube, just to answer for the couple folks that are asking that question. And then we just now have another question that came in through the queue. And it says, given the increase in beneficiary enrollment in MA plans across the country, can anyone speak to the anticipated provider shortage versus the significant increase in the Medicare population over the next 10 years, and how MA plans intend to be able to continue to provide adequate network access and quality care?
Yeah, Mary Beth, I'll take a first stab at that. It's a great question. And I think we're all thinking about how to do what we're doing in more efficient ways. And to be honest, the time is now. As you've probably seen in the news, there are staffing shortages around the country due to COVID, just some of the staff becoming ill themselves. There is also some repercussions because of the vaccine mandates, and some of the staff have decided to leave. Given all of that, plus what we've heard about the Great Resignation, that's affected healthcare as well. I think every healthcare organization that I've talked to recently is evaluating how to deliver great care, but do it as efficiently as possible. Healthcare is a very people-intensive operation, be it in the hospital or be it in the outpatient world. But we have to figure out how to do it more efficiently and better. And I think technology is part of that equation. We can't lose the human touch, but figuring that out, I think, is a big challenge for our medical groups and health systems. One option is that many of our groups have pivoted to, as Dr. Spencer mentioned, is telehealth. Really figuring out what's the appropriate place for telehealth in the future, I think, is one of the challenges that we'll all be thinking through the next few years. But perhaps, and this gets to the rural issue, bringing telehealth to the patient through specialists that may not be available in that local community is one thing that many groups are looking at. But this is a huge challenge, and I think we're all going to be thinking hard on this for the next 5 to 10 years.
Yeah, I would add that technology will be a piece. The other part that Jerry mentioned earlier, and really Ipyana represents this, is this overall care team model. So, one is at its core, we must make primary care more attractive. The payment model needs to be fair and just, and we have to incent folks to want to take care of our neediest population as this population grows. So I charge all of us with fixing that going forward. And, I think some of the decisions upcoming are important to that. But beyond that, in the payment model of fee-for-service, the only way the physician is paid is for the patient to come into their office. There is much care we can give without having that patient come into their office, with pharmacists, nurses, home visits, social workers, other caretakers. That is a way to multiply the primary care and provider experience, while we have a shortage in specifically primary care doctors. I think the APP care model is going to be a big important piece of this going forward, and many groups are beginning to learn how to work in that model in an efficient way and deliver great care.
Thank you, Dr. Penso, and thank you, Dr. Spencer. I know we've gone over. I appreciate our panelists said that they could stay an extra few minutes. So I did want to see, Jonathan, if we had other questions.
Looks like there's a couple questions in the queue that may be best answered offline.
Okay.
So I don't see any other questions at this time.
Okay, we will do that. Well, again, I know personally I could ask more questions, but I need to cut my own self off. But I appreciate just the dialogue that I've been able to have with our 3 panelists here, and as well as Matt with Avalere. Greatly appreciate the expertise that you shared, and thank you, Ipyana, Dr. Penso, and Dr. Spencer. And I did want to, for the Hill audience that joined us on the webinar, that as we talked about the upcoming rate notice and the proposed rule that's out there, we do are pleased to share that there is a House and a pending Senate letter that's being worked on, and it closes today, that both House members on the Republican and Democratic side are signing on to, showing their support for Medicare Advantage at this time. And I know Jonathan's going to show a slide that gives you points of contact if you haven't already signed on to that. And we have many who have already agreed to sign. So for those of you who are with members of Congress who have already signed, thank you very much. Thank you for representing your constituents. And I just want to remind folks that BMA is here as a resource to you. As MA is in states throughout the country, we want to be a resource to you as you're serving constituents, both in MA and those who are looking to choose MA. So thank you very much. Have a good rest of the day, everyone. And thank you again for joining our webinar. And thank you so much to our BMA allies.